Hello, Dr. Mandeep. We would like to have clinical insights on some issues. Indian PCOS is different considering the ethnicity as per the clinical studies. Do you agree that Indian PCOS is different as compared to Caucasians and needs a different treatment option?
Yes, Indian PCOS women have a severe metabolic phenotype. In Indian PCOS women, we observe hyperandrogenism, hyperinsulinemia, acanthosis nigricans, hypertension, as well as type 2 diabetes. While in Caucasians, hyperandrogenism is more observed. So, while treating Indian PCOS patients, we try to manage the insulin resistance part in the treatment.
What is your approach while treating the Indian PCOS women in view of higher insulin resistance explained in recent studies? What is the difference in the management of lean and obese PCOS patients in your practice?
So, in Indian PCOS women, as per the recent studies, insulin resistance is treated because we do not aim till conception. We aim to have live birth rate, increase live birth rate. And for treating insulin resistance, we have insulin sensitizing agents like metformin, and even myoinositol gives a very good result. These two drugs, if used in combinations, they reduce the insulin resistance, they correct the metabolic as well as the hormonal milieu of the body. It improves the oocyte quality also of the patient. And now, as you've asked about the lean and the obese PCOS patients, this is very commonly asked in the OPD also. The lean PCOS patients are advised dietary modification. Now, in the lean patients, already they are maintaining a weight, so we tell them to eat more iron rich diet, vitamins, minerals, a balanced diet so that they maintain the weight which they are carrying. Also, the lifestyle modification to inculcate the habits of exercise, walk in their daily activities. While in obese PCOS patients, we tell them to have a calorie restricted diet so that they do not put on more weight. So we help them in this weight loss journey, we help them in achieving their goals. As well as exercise activity, you will understand. Plus the addition of these insulin sensitizing agents like metformin as well as myoinositol do help us in achieving their goals in the PCOS patients, whether it is a young girl requiring regular cycles, or it's a newly married girl who's planning for her pregnancy, or it's a girl in the premenopausal age where she's more worried about the metabolic changes in her body like diabetes or hypertension. So these lifestyle modifications do help the lean as well as the thin PCOS patients.
When a woman with PCOS gets conceived, do you consider it as high risk pregnancy? If yes, what may be the complications? How do you manage or prevent them?
Yeah, when a patient with PCOS conceives, yes, we do take it as a high risk pregnancy because then there is a threefold risk of abortion in the early trimester. As well as if it is an obese PCOS patient and she has conceived, then she's more likely to develop diabetes, hypertension, and even if uncontrolled, she might land up in preeclampsia. So here the guidelines say that use of metformin helps in controlling the insulin resistance as well as decreases the miscarriage rates.
Okay, ma'am. Threatened abortion and miscarriage due to luteal phase defect are some other worrying factors during pregnancy. Do you consider dydrogesterone as a better treatment option compared to micronized progesterone?
Yeah, dydrogesterone has come up in the market recently very nicely because we are seeing a few good features about dydrogesterone, like its bioavailability is more, its dosage is less, it causes more insulin receptor, it is more selective towards the insulin receptor, and it does not produce the neurosedative effect which was observed in the progesterone component.
What are your major concerns regarding available progesterone formulations?
Regarding the available progesterone formulations, if we talk about the vaginal progesterone, which is a very good in specific indications, it is giving beautiful results. But in routine patients, it can cause more itching, dryness, even inflammation in some patients, pain, and so it is a bit difficult for the patient to use as encountered in our practice. We need to motivate the patient more in the particularly indicated cases like in cervical incompetence or shortening of the cervical length. If we talk about the oral progesterone, then the bioavailability of oral is a shade lesser than the dydrogesterone. And coming to the third dose, that is injectable progesterone, the pain and the local site reactions are few things where we weigh which one to use, although they have their own usage in different indications, tailor-made.
In your clinical practice, when do you start, for how long, and in what dose do you recommend dydrogesterone in threatened abortion cases?
If a patient has had a history of recurrent abortions and in this pregnancy also the patient is coming up with episodes of bleeding, I would like to put her up on 40 milligrams of dydrogesterone as a loading dose, and then we give 20 milligrams for a week after the bleeding stops.
Today in India, intravenous iron is used as a reserved option for treating severe iron deficiency anemia. Looking at the comparatively superior benefits of intravenous ferric carboxymaltose, what could be the barriers for using it in every patient of moderate and severe anemia?
Yeah, intravenous ferric carboxymaltose is a very good medicine. It is more efficient and the results are seen. But the cost factor is one which is actually limiting us from the use of ferric carboxymaltose injectable.
In view of growing number of cesarean sections and prevailing lower hemoglobin levels in pregnant women, there are high chances of them landing in postpartum anemia. Considering non-compliance to oral iron, do you feel the need of administering parenteral iron before discharging them from the hospital?
Yeah, if oral iron the patient is non-compliant to the oral iron, then in such cases in the postpartum period, if the hemoglobin is around 8 milligrams per deciliter, I would definitely consider giving her injectable iron, and it is a good option for the patient as the iron level builds up and the patient achieves good hemoglobin levels in the postpartum period.
Thank you, Dr. Mandi.
Thank you.